This conference will now be recorded.
Hello, can you hear me?
Yes, ma'am.
Okay. Today's class is on amniotic fluid abnormalities. మా మూవ్ అవట్లేదు ఇది స్ట్రక్ అయిపోయింది So before going to the amniotic fluid abnormalities, we should know about the amniotic fluid. Where from this the amniotic fluid is coming? Mostly it is mixed origin, both from maternal and fetal origin. Usually the water in the amniotic fluid is completely changed and replaced every 3 hours. There will be presence of longohead, epithelial scales, because the fluid is swallowed by the fetus and some of it passes through the gut into the fetal plasma. So coming to the volume, it is about 50 ml at 12 weeks, 400 ml at 20 weeks, 36 to 38 weeks it reaches the peak. This you have to remember. And it is about 1 liter. Thereafter, by 40 weeks, it will usually the amount decreases by 600 to 800 ml. This is mostly important, these values. 36 to 38 weeks, it is 1 liter. At term, the amount of fluid decreases to 600 to 800 ml. As the pregnancy continues still further, that is postpartum pregnancies, 200 ml at 43 weeks it will be. So 12 weeks 50 ml, 20 weeks 400 ml, 36 to 38 weeks it is the peak value, that is liter, and thereafter it decreases to 600 to 800 ml. These values you have to remember. Then coming to the features, it is usually alkaline and color is usually colorless, but only at the term it is pale straw color due to presence of longo and epidermal cells, and turbid due to the presence of vernix caseosa. Okay, usually colorless. At term it will be pale straw color. But this color is very much important because their abnormal colors are there which warn us for the fetal distress. If it is green amniotic fluid color, it indicates meconium stain. That indicates fetal distress. If the color is golden color, it is usually seen in RH incompatibility fetuses. Greenish yellow, saffron, it is seen in post-maturity. Dark colored, black colored, it is in accidental hemorrhage. Tobacco juice color, it is usually indicates intrauterine death of the fetus. So these colors usually they will ask you in exam. So meconium stain means what's the color? It is green color. RH incompatibility, golden color. Post maturity, it is greenish yellow. Dark colored in accidental hemorrhage. What is accidental hemorrhage? Usually there will be bleeding inside because of placental separation. So the color of the liquor will become dark because of presence of blood. Dark brown due to IUD. Okay, the composition is simple. It is mainly water, and solid components consist of protein, glucose, uric acid, creatinine, urea, and some hormones are also present. They are prolactin, insulin, and renin. Okay. And not only that, inorganic compounds such as sodium chloride and potassium are also present. Among that, a suspended particle, there will be longo, exfoliated squamous cells from the fetal skin. Skin cells will be present, longo cells will be present, vernix caseosa will be present. And not only that, cells from the respiratory tract, urinary tract, and vagina of the fetus are also present. Okay. What is this function of amniotic fluid? What is this function? Mainly it is due to, it will protect the fetus. During pregnancy, it acts as a shock absorber. The fluid will be present, it acts as a shock absorber. It maintains an even temperature and allows for the free movement of the fetus and prevent adhesion to the uterine wall between fetal parts and amniotic sac. And nutritive value is very less, mainly shock absorber, maintains even temperature, allows the growth of the fetus, and free body movements will be present. Okay, and there won't be any adhesions. During labor, what does it do? The amnion and chorion are combined to form a hydrostatic wedge, helps in dilatation of the cervix. During uterine contractions, it prevents marked interference with the placental circulation as the membranes remains intact. It's guard against umbilical cord compression. And not only that, the amniotic fluid has bactericidal action. During labor, it helps in dilatation of the cervix, number one. During contraction, it prevents interference in the placental circulation to prevent guard against umbilical cord compression. Number four is bactericidal in action. So from where this amniotic fluid is produced? I already told you it is from both maternal and fetal. In the beginning, usually it is from the maternal serum, number one. Number two, it will be from the amniotic. It is surrounded by amniotic membrane, isn't it? Secretion from the amniotic epithelium. Number three, from translation from fetal circulation. Number four, from the fetal skin. Only up to 20 weeks, the secretion will be there from the fetal skin. After that, what will happen? There will be thickening of the fetal skin will be present. That is known as keratinization of the fetal skin at 20th week. From that day onwards, usually the amniotic fluid is formed from the fetal urine and respiratory tract. Fetal urine daily output at term is about 400 to 1000 ml. And fetal lung that enters the amniotic cavity adds to its volume. So, production is mainly from maternal transudation, from the amniotic epithelium, from fetal transudation from the across the umbilical cord, transudation from the fetal skin, from fetal urine and fetal lung. This is the production. And removal, not only the producing, the fetal swallows about 500 to 1000 ml of liquor every day. And not only that, intramembranous absorption of water and solutes will also be present. So this is the removal. So this is the circulation, you have to remember. This is the amniotic epithelium, maternal serum, fetal skin, fetal urine, placental transudation, maternal circulation, all this will contribute to amniotic fluid. They will ask you in the exam, okay? From fetal circulation, exchange with lung fluid, the fetus swallows about 400 to 700 ml, and intramembranous transport will also be present. This much you should know about the amniotic fluid. So coming to the polyhydramnios. Polyhydramnios is nothing but excess amount of liquor. It exceeds 2000 ml. Okay, already I told you around 12 weeks 50 ml, 20 weeks 400 ml, 36, 38 weeks it will be later it will be decreased to 600 ml to 800 ml. But here if it exceeds 2000 ml, it is known as polyhydramnios. Clinical definition is the excessive amount of liquor amylase causing discomfort to the patient when the amniotic fluid index is more than 24 centimeters. What is amniotic fluid index? We have to take single vertical pocket of amniotic fluid in all four quadrants, taking umbilicus as the center point. When you take the four quadrants amniotic fluid, if you sum up, it will give the index. More than 95th percentile in the gestational age, or deep vertical pocket is more than 8 centimeters. Incidence is about 1 to 2%. Listen properly, because it is can be given in the exam. It is a anencephaly is there for the specimen, and they will ask you in polyhydramnios. Usually they will ask in the orals also. Okay, so polyhydramnios may result either deficient absorption as well as excessive production. It can be a temporary or permanent. What is the etiology? 50 to 60% it is idiopathic. Cause is not there. And fetal anomalies, paternal problems, and placental problems will come into play. This is the etiological for the polyhydramnios. Coming to the fetal anomalies, fetal causes, congenital fetal malformations are associated with polyhydramnios in about 20%. Usually, the commonest condition usually we see are anencephaly. See, this is the anencephaly where the vault is absent, isn't it? Here the vault is absent, all the meninges are exposed. And this is the fetal anomalies. This is the esophageal atresia. So it can't swallow. Here it is spina bifida. There will be exposed meninges, cleft lip and cleft palate, where the baby can't swallow properly. Hydrocephalus and aneuploidies. So we'll go back. Fetal anomalies. The first one is anencephaly. This is also a specimen for you. Listen, they will ask you why there is polyhydramnios. What is the cause for polyhydramnios in this specimen in your orals? Why? Because of excessive production of liquor amnia due to translation from the exposed meninges. There will be absence of fetal swallowing reflex in anencephaly baby. And number third one is possible suppression of fetal antidiuretic hormone leading to excessive urination. So antidiuretic hormone is suppressed. Absence of fetal swallowing reflex and exposed meninges. They will ask you this question. Each and every person, they will ask you. You have to remember this. There are other fetal anomalies which are what are the conditions you will come across in polyhydramnios. This also they will ask you. Open spina bifida. There will be increased translation from meninges. Esophageal and duodenal atresia. They will prevent swallowing. Okay. Whenever there is closure. Atresia means closure, isn't it? Facial left lip and neck masses interfere with normal swallowing. Hydrocephalus and aneuploidia are genetic syndromes. So these are the babies. Next comes the placental causes. What is chorioangioma of placenta? This is a tumor growing from a single villus. There will be increased translation will be present in this chorioangioma of placenta. Then comes the multiple pregnancy. Hydramnios is the most common in monozygotic twins, especially when there is TTTS. What is TTTS? Twin to twin transfusion syndrome. In this case, one fetus will develop poly and one fetus will develop oligo. Coming to the maternal causes, the important one is diabetes. Why there will be diabetes? There will be polyhydramnios. This also they will ask you in exam. Because raised maternal blood sugar leads to raised fetal blood sugar. Whenever there is blood sugar, what will happen? They will have polyuria, polydipsia. You know about diabetes, isn't it? There will be fetal diuresis that leads to hydramnios. Then comes the cardiac and renal diseases. May also leads to edema of the placenta, leads to increase in transudation. Then polyhydramnios, there are of two varieties. Commonest is the chronic variety. Usually the onset is insidious. That is, slowly it will take few weeks. In acute variety, its onset is sudden. It occurs before 20 weeks of pregnancy. And it is very rare. It is usually associated with PAH. Sorry, the existing chronic variety it can be. This polyhydramnios can be mild, moderate and severe, depends upon the scan findings. The deep vertical pocket is more than 8 to 11 centimeters. It is called mild. Moderate is deep vertical point between 12 to 15. Severe is more than 16 centimeters. This is the single pocket. And what are the symptoms usually they can have? So many cases, accidentally they will be seen. Sometimes, if severe cases, they can develop respiratory, that is shortness of breath, palpitations, edema of the legs, varicosity of legs or vulva, and hemorrhoids. This is the usual symptom. The patient complains of respiratory distress, palpitation and edema. Usually they will complain, and we can also see varicosities and hemorrhoids. And the signs are usually the patient is usually in the dyspneic state if it is severe polyhydramnios, and associated conditions such as preeclampsia will also be coexist. On abdominal examination, what will be there? The height of the uterus will be more than the period of hemorrhage. In the inspection only you can make out the abdomen is markedly enlarged. It is fullness in the flanks will be present. As there is fluid is there inside, the skin is tan, shiny, and stria gravida are more prominent. On palpation, height of the uterus is more than the period of amenorrhea. The abdominal girth is more than the normal. Fluid thrill can be elicited. Here the fetal parts presentation position may not be properly identified. In mild cases, we can identify, but in severe cases, we may need the help of ultrasound. And external ballotments can also be elicited. And auscultation fetal heart sound can be heard with Doppler or by ultrasound help can be taken. But if you do the internal examination, because of polyhydramnia, the cervix is always pulled up and partially taken up. There will be a dilatation of about 1 finger where you can feel the membranes bulging. Okay. So you remember maternal causes, fetal and placental causes. They will ask you mild, moderate, severe and symptom signs. And what are the investigations you are going to do for this case? Apart from routine investigations, what are the routine investigations? Hemoglobin, complete blood picture, urine albumin sugar micro. Later we have to go for the, if they are associated with PAH, that is preeclampsia, we have to do renal function test. Then ABO incompatibility, because RH immunization is associated with polyhydramnias. Random blood sugar is important. Glucose tolerance test also, if necessary, we have to do, because maternal diabetes is associated with polyhydramnias, isn't it? Not only that, alpha fetoprotein, which is elevated in case if the baby is having congenital anomalies such as open neural tube defects. So alpha fetoprotein also we have to do. Apart from routine investigations, we have to go special investigations such as a blood grouping, random blood sugar, amniotic fluid, alpha fetoprotein, and also renal function test we have to do these cases. And ultrasonography, what are the things we have to see? We can first diagnose whether it is singleton pregnancy or multiple pregnancies, because multiple pregnancy is associated with polyhydramnias. And we can, and not only that, we can see lie, presentation, position, and any congenital anomalies are there, we can make out. And not only that, amniotic fluid index and amniotic deep vertical pocket volume also we can make out. And how you are going to manage this chronic polyhydramnias? How you are going to manage early detection? If the mother is having diabetes, we have to control it. If the RH incompatibility is there, we have to take the precautions for doing, even for the anti-D injection at 28 weeks. Genetic counseling to be done if there are any congenital anomalies. If it is mild polyhydramnias, what to do? Usually it is seen in the mid-trimester. What we have to do? Already first I told you, the liker is more, about 1 liter, about 36 to 38 weeks. By coming to the term, usually it decreases. So we have to wait and watch policy. Only the problems we have to treat, and excess liker is expected to diminish on its own as the pregnancy advances. So we have to wait. If it is severe, our main aim is to find out the cause, one, to relieve the symptoms, and if any complications are there, we have to deal with them. So first thing is bed rest. If it is associated with PAH or diabetes, we have to control them. Use of COX-2 inhibitor, Sulindac, 200 milligrams every 12 hours can be given. See, here we have to admit the patient. See here, we have to do postpone blood sugar, GTT if necessary, HbA1c if the patient is diagnosed as diabetes. For any infections, we have to see, and RH incompatibility we have to see. For doing ABO blood grouping scan we have to do. If there is no fetal abnormality, it should be referred to the maternal fetal unit and pregnancy to be terminated. If there is no abnormality, response to treatment is there, we have to continue the pregnancy, wait and watch policy. If any complications are there, we have to deliver a term. If there is maternal distress, the patient is having respiratory distress or palpitations. If it is less than 37 weeks, we can go for, previously we used to go for amniodeduction. If it is more than 38 weeks, we can go for stabilizing oxytocin drip, ARM can be done, and we can make the patient delivered. So it mainly depends on fetal abnormality is there or not. Abnormality is there, terminated. If no abnormality, our remote from term, we have to wait and watch policy, and we have to see for any associated problems. If it is maternal distress is there severe, we can go for amino reduction. And if it is beyond 38 weeks, we can induce the patient for labor. So what is amniocentesis? Slow decompression is done at a rate of 500 ml per hour, and the amount of fluid to be removed should be sufficient enough to relieve the mechanical distress. See like this. We have to, under ultrasound guidance, we have to see so that injury to the fetus or placenta can be avoided. So about 500 ml can be removed per hour. Okay. Normally, amino drainage is stopped when the amniotic fluid index is less than 25 centimeters. But even though how much ever you take, again reaccumulation is the problem here. But a little bit transient, the comfort will be present for the mother. It will reduce the mechanical distress. And this amniotic fluid which is removed can also be tested for fetal lung maturation. And what are the complications you expect in a case of polyhydramnios? This they will ask in exam. During pregnancy, what? Preeclampsia is associated. Because of more amount of fluid, there can be malpresentations and persistent fetal head. The fetus won't get engaged. Premature rupture of membranes, preterm labor, or sometimes accidental hemorrhage. These are the complications we'll expect for the mother. So, preeclampsia, malpresentations, PROM, preterm labor, and accidental hemorrhage. During labor, early rupture of membranes, cord prolapse is more common. Uterine inertia, it takes more time to get contracted. Increased operative delivery due to malpresentations, and retained placenta and PPH is more common, and shock are common during labor. In the puerperium, there will be subinvolution because by big uterus, it will take long time to come to the normal, and there will be chances for infections because of operative interferences. And coming to the fetus, prematurity, congenital abnormality, hydrops vitalis, operative delivery problems we can come across for the fetus. So they will definitely ask you whenever you get a case of anencephaly also for the posture, as well as for the case they will ask you these problems during pregnancy, during labor, and during puerperium you have to tell. Then comes the oligohydramnios. Oligohydramnios is defined as reduction of amniotic fluid as evidenced by an amniotic fluid index of less than 5 centimeters or single deep pocket less than 2 centimeters. This they will ask you. Oligo means single deep pocket less than 2 centimeters or amniotic fluid index less than 5 centimeters. An amniotic fluid index between 5 and 8 is considered borderline or low normal amniotic fluid volume. Oligohydramnios is usually suspected when the uterine size is less than the appropriate for the gestational age. Women with pre-labor rupture of membranes may present with history of vaginal discharge. What are the causes for this oligohydramnios? In the maternal, they can be premature rupture of membranes, postpartum pregnancy, preeclampsia, pregestational diabetes, placental abruption, and dehydration are the causes for the oligohydramnios. Coming to the fetal causes, there will be twin-to-twin transfusion, congenital anomalies such as renal agencies, outflow obstruction to urinary tract, polycystic kidneys. These are the main causes for the oligohydramnios. Not only that, chromosomal abnormalities such as triploidy, trisomy 18, and Turner syndrome. And if the patient has used drugs such as prostaglandin synthetase inhibitors or ACE inhibitors, there are more chances for oligohydramnios and idiopathic. These are the causes. So maternal or preeclampsia, postpartum pregnancy, pregestational diabetes, placental abruption and dehydration, fetal or twin-to-twin transfusion, IUG or congenital anomalies such as mainly they will ask what are the congenital anomalies responsible. They are renal agencies, outflow obstruction to urinary tract and polycystic kidneys. Chromosomal abnormalities and drugs and idiopathic are the causes for oligohydramnias. What are the complications if you have oligohydramnias? For the maternal, they can have chorioamnitis, instrumental delivery. There are more chances for the prolonged labor and cesarean section. Okay, because if the lichen is very less, immediately we used to take for the cesarean section suspecting fetal distress. And for the fetus, there are more chances for abortion, deformity, fetal lung hypoplasia, cord compression, and high fetal mortality will be present. And how you are going to elicit? History is more important when any discharge, that is watery or blood-stained vaginal discharge, we have to inquire. Any history of hypertension or preeclampsia, pregestational hypertension, any antiphospholipid antibody syndrome, and family history of any anomalies in the baby or chromosomal abnormalities we have to ask in the history itself, and history of any drug induction, drug users we have to ask for the any medications in the history. And physical examination, as we already told you, we have to see for the blood pressure. PET is more associated with oligohydramnias, and uterine size is less than the gestational age. On palpation, the height of the uterus will be usually less. On speculum examination, they can be watery or blood-stained discharge will be present if there is PROM. And when you palpate, the uterus is full of fetus because of scanty liquor, and moreover, it is mostly associated with breach. And evidence of IUG is also will be present. On speculum examination, they can be watery or blood-stained discharge, pooling of fluid in the posterior fornix. And coming to the investigations, USC is to confirm the diagnosis and to estimate the amniotic fluid index. If oligohydramnios is confirmed, USC has to detect any fetal anomalies are there, any renal agencies, polycystic kidneys, outflow obstruction, any chromosomal abnormality markers we have to do, and fetal growth restriction we have to see. The placenta should be localized and abruption should be ruled out. If there is history of watery vaginal discharge or rupture of membranes, we have to exclude by speculum examination. If there is no watery discharge, microscopic examination of vaginal swab for ferning or detection of vaginal pH by nitrogen test will confirm the rupture of membranes. So if you can't see by speculum examination when any leaking is there, we can do nitrogen test, or we can see for the vaginal pH method. How you are going to manage? Mainly depends upon the gestational age and diagnosis, the cause of oligohydramnios and fetal prognosis. Always advise them bed rest. They should take plenty of oral fluid. They will ask you in the exam. L-arginine sachets. We can give either BD or TID. IV fluids if required. And amino infusions. In our hospital, we are giving Hermin infusions. Either weekly once or twice, depends upon the patient amniotic fluid. And the first trimester, if you are seeing that lichen is reduced, always think for the any anomaly. Always see for the serial ultrasound is required. And counseling is very much important in these cases. The second trimester prognosis is poor, but counseling is important. The underlying cause should be determined. Amino infusion can be done, and termination is required if the fetus is having an anomaly, and follow up of serial ultrasounds to be done. In the third trimester, in the last trimester, if that depends upon the, already I told you, postpartum pregnancies with reduced AFI should be delivered. If the fetus growth is restricted, the fetus should be monitored by serial ultrasonography combined with uterine and middle cerebral artery Doppler. Delivery should be dictated by fetal condition. Women with preterm rupture of membrane should be managed conservatively till 34 weeks with close monitoring and delivered if leaking of fluid is present. Women with idiopathic oligohydramnios should be observed and monitored by non-stress test, serial ultrasonography, and biophysical profile. Timing of delivery. When the etiological factor is detected, timing of delivery is guided by specific conditions such as preeclampsia, growth restriction, and fetal anomaly. Pregnancies with idiopathic oligohydramnios should be delivered by 38 weeks or when there is non-assuring fetal status. Management in labor. Close monitoring is essential. Electronic fetal monitoring is recommended. Membrane should be ruptured when the woman enters active phase of labor to look for the meconium. If meconium staining or fetal heart rate decelerations are present, we can shift to cesarean section. Okay? Thank you. Do you understand? Are any questions do you want to answer me? Any questions for me? Hello? Thank you.
No, ma'am.
When you are coming, any intimation?
Not yet, ma'am.
Not yet. Okay. Thank you.